Hello and welcome to the East of England Health and Care Academy's Healthcare Careers in Focus. Thank you for joining us. Our first session is around mental health, and I'm now going to pass you over to Stacey, who is our first ambassador. Thank you, Stacey. Over to you.
Hello. Did you, Stacey, you've got my presentation, haven't you, that you can access? So I'm a mental health nurse and I work on the mother and baby unit. It's called Kingfisher Mother and Baby Unit, and I work with mums who are pregnant or have had their babies, and their babies are up to a year old. So I'm just going to have a little talk about my career journey, how I got to where I am, and then just a little bit of a talk about the work that I do on the mother and baby unit. I am on shift at the moment, so hopefully there won't be any disturbances, but I might just have to mute for a second if someone comes to the door. Yeah, can we change the slide? Thank you. So I started off as a nursery nurse, and I worked as a nursery nurse for quite a few years. From that point, so I've always enjoyed working with children, but from that point I then moved into my role as a family support worker, and I worked as in Sure Start, so that meant I worked with mums and their children up to the age of 5. So already I was starting to progress from children to kind of family work, which I really enjoyed. The children's centres went out to tender, which meant that different organisations took over the children's centres. So from that point I decided to look for something else. So I moved into a family support role still, but I worked with the ADHD team as a family support worker, and alongside that I was a specialist nursery nurse for children who were under assessment or had a diagnosis of autism spectrum disorder. From that point there is when I did a bit of a jump, and that's when I moved into mental health. So I got a role as a trainee assistant practitioner with the youth team at 80 St Stephen's, and I worked within a neurodevelopmental service as part of the youth team. So that was working with young people from the age of 14 to 25 who had a diagnosis or were being assessed for autism, tic disorder, ADHD, and I worked doing kind of mental health support. Alongside that, I was doing a foundation degree in mental health. So being from a trainee assistant practitioner, I needed to complete a 2-year course in a foundation degree in mental health at City College. So I did that alongside my role. When I completed my foundation degree, I then went on to do meds management. So that was an 8-month course where I learned about medication and the things that I needed to do to be able to safely administer medication. And I needed to do that step because I knew I wanted to become a nurse, and to access the nursing pathway I needed to do the meds management course. So I did that, and then COVID hit, and I decided that I no longer wanted to work in the community, and I saw a job for an assistant practitioner on Kingfisher Mother and Baby Unit. So I made the move to Kingfisher MBU, where I was an assistant practitioner, and they supported me to do my foundation degree, to do my nursing degree. So I took an apprenticeship route, which meant that I was employed by NSFT. It was a 2-year course that I went to the University of Suffolk. And I remained working on Kingfisher MBU as an AP, but went to uni at the same time. And then I had block placements. So I had 5 different placements, all different around the trust. And that took 2 years. I qualified in February, and I was offered a post on the mother and baby unit. They'd supported me for 2 years to do the nursing, and then they offered me a nursing role. And so I'm over halfway through my preceptorship now. So yeah, that's kind of my career journey in a nutshell. So can we go on to the next? So I suppose I thought it would be helpful just to find out a little bit about what an MBU is. I don't know, before I start that, if anybody had any questions just about like the apprenticeship route or the foundation degree route. I know things look slightly different now from when I qualified, because there's now the nursing associate option, which wasn't available when I first started. But if anyone does have any questions, you can just pop that in the Q&A. So an MBU is it's a specialist inpatient unit for women who have mental health difficulties during pregnancy or after the birth of their child. So before MBUs existed, if you became mentally unwell and you needed hospital placement, you were separated from baby and you would go onto an acute ward. So the idea about a mother and baby unit is keeping mum and baby together. There is only, I think, like 19 MBUs across the country, maybe not even that many, but there's not as many MBUs as there are acute wards. So the staff, the idea is they nurture and support the mother and infant relationship at the same time as we are offering mums treatment for the mental illness. So we can admit mums late in pregnancy. So that's we take from like 28 weeks pregnant, and they can stay until baby is up to a year, and we don't take any over a year. It's really different to an acute ward. So although we are an acute ward, it has a really different feel. So we're an 8-bedded unit, and we have, I suppose, fewer restrictions to some of the other wards because we have babies on the ward. The way we look at risk and way we manage risk is slightly different. We work really closely with the community perinatal mental health teams and maternity services and health visitors. We work alongside the Lotus team and the teams at the NNN. For any of our mums, if they've got those kind of teams involved, we will work with them throughout their journey. The mums have their own bedrooms. They have an ensuite. They have a cot or a Moses basket in their room. So the idea is that they're kept together throughout kind of their time on the ward. Let me change the slide. So some of the perinatal mental illness, some of the mums that we see will have a diagnosis of bipolar, schizophrenia, depression, anxiety, OCD, postpartum psychosis, complex post-traumatic stress disorder. Some people might have these diagnoses prior to admission. Some people might then get diagnosed during the admission. It might be somebody's kind of first experience of poor mental health, or it may be something that somebody's struggled with kind of throughout their adult life, or even younger years. But in order to be on the MBU, it needs to be kind of exacerbated by the perinatal period. So we do have some exclusion criteria. So in general, that we don't offer admission to women with a severe personality disorder, learning disability, or substance misuse unless they also have a serious mental illness. So if those things are standalone, then we wouldn't ordinarily offer a place on the MBU. But each referral that comes through is triaged, and we will discuss that as part of an MDT. Any women who have very aggressive behaviour that might pose a risk of harm or injury to themselves or their own or other babies. So again, this doesn't mean to say that somebody could not go to an acute ward and then be transferred back to us. But at that moment in time, if somebody is presenting really acutely unwell with aggressive behaviours, then we wouldn't accept them until those risks have reduced. Women who are unlikely to be able to care for a baby independently. So even if reasonable support, so if somebody needs kind of living in supported accommodation or needs to have somebody with them frequently, we wouldn't be able to offer them a place on the MBU, because we can't offer that same level of support if somebody needs support with their parenting in that way. Or women who just need an assessment of their ability to parent, but who do not need treatment for a serious or complex mental health illness. So again, sometimes people get confused and they think that we're a parenting assessment unit, but that's absolutely not what we are. We're here to treat mental health. Next slide, please. So that we have lots of different staff on the MBU. So that consists of nurses, nursery nurses, clinical support workers, nursing associates. We have an occupational therapist and an occupational therapist assistant practitioner. We have clinical psychologists, a parent and infant mental health therapist, peer support workers, consultant psychiatrists. We have pharmacists. So when we make these MDT decisions and talk about kind of care moving forward or triaging referrals, we will often have lots of different disciplines involved in those kind of conversations. So I thought it would be helpful just to do a little kind of day in the life, I suppose, of a nurse on a mother and baby unit, because it can look different. So I kind of just spent some time writing down some of the things that we do. So we have handover, and we have that 3 times a day. So we have handover in the morning, we have it at lunchtime when we have our late shift come on, and we have it again at night when our night shift comes on. We need to complete safe care, which is when we look at staffing levels. So we have a little look at what staff we've got and use that alongside what things that we need to be offering during the day. So if we've got any one-to-one observations, if we've got any groups running, if we've got any additional obs, ward rounds, things like that. So we just have a look at what tasks we've got and what staff we've got, and make sure that we've got enough staff and the right staff mix to be able to manage the ward safely. Excuse me. We also then need to do the allocation of staff. So again, if we've got any one-to-ones, we need to think about who's best suited to do that. So any staff looking after babies on the ward. So the idea is mums do most of the care, but sometimes due to risk or poor mental illness, we will support mums and we will be on a one-to-one with the baby, and that means that we need to have staff who have baby competencies, so understand kind of how to make a bottle, to change nappies, how to soothe babies, developmentally have an understanding of their needs, so we can make sure that they are supporting mum in the right way as well. So we will always try to be the least restrictive and empower mums to carry out the care. So we would do medication rounds, so we do the meds round in the morning. Any medication that is not available or running low, it's then up to us to make sure that we order that. Anybody who's going on leave or being discharged, we need to make sure during that medication time that has been ordered. We also have a daily task list, so anything that's outstanding that needs to happen for those patients, we would allocate accordingly. So if people need their rights read, if they need physical observations taken, we'll look at what staff we've got and allocate that again through the day. We use Teams to do that, so it just means that we can kind of update, keep an update on that. Care planning, risk assessments, we update those weekly, or if any significant events happen, that we need to make sure that they are up to date. Ward round, so our mums will have a weekly ward round and they run on a couple of different days, so we make sure that we're attending in there, make sure that we can share our general nursing report, but also that the mum's voice is being heard, so we kind of act as an advocate on their behalf as well. Offer supervision to colleagues, so line management or clinical supervision. We offer daily one-to-ones to patients, so again, just to make sure they're doing okay. If there's anything they need, they can be planned, but they can also be sporadic depending on how the day goes and how people are feeling. We offer carer support, so to families and partners. We offer to signpost for like carers assessments or wellbeing referrals. So it's helpful to know that if a partner their partner is under perinatal mental health services, that they can have a referral made to wellbeing services, and they will be seen as a priority, because we know that patients or partners of patients under the perinatal service do need additional support. We carry out aspects of baby care at times and run groups. So our normal staffing levels are 6 on the early, 6 on the late and 4 on the night, and that allows for us to have 1 or 2 one-to-ones within our numbers before we need to get extra staff. I've just seen as well in the questions just that what branch of nursing you would apply for to work on an MBU. So it's mental health nursing. Although we have had people before who have done a nursing course and have been a learning disability nurse, but most of our nurses on the ward are mental health trained because we need to be able to accept Mental Health Act paperwork and things like that. So mostly people go down the mental health nursing route to do that. I don't know of any children's nurses that have been on the ward. We have had a midwife. Our ward manager is a midwife, so there is some flexibility there. Thank you. So rewards and challenges. So what I did for the rewards and challenges is I actually asked some of my colleagues what they found rewarding and what they found challenging about working on the ward. So there's just a range of different things. So someone said being able to begin to break down intergenerational traumas. They liked having a specialism. They liked seeing people get better and doing things that they couldn't do before. They liked, and some of these are duplicated as well, so that some people said that, you know, similar things, that we don't just treat mum, we treat the family and promote really good life outcomes for mum, baby, siblings and partners. They like being part of a team. No day is the same, and we have the luxury of being able to share our skills because we've got such a wide, I suppose, wide range of occupations on the ward. It means that we can all share our thoughts and our experience and our knowledge with one another, and that's, you know, that's really beneficial. Some of the things that can be difficult are ward rounds can feel a bit impersonal. Sometimes that we have had babies removed from the ward, so they've either gone home with family, which means so mums can't be on the ward without their baby. So it means if mum's no longer able to care for baby for whatever reason, then baby needs to go home, whether that's going home with family or going with children's services to a foster placement. That can be really difficult. It means that mum has to transfer to an acute ward and baby goes home, and sometimes mums are here without their babies for a few days if we can't find them an acute ward placement. Breakdowns in therapeutic relationships. Planning sessions around a baby's routine. So sometimes that you can kind of plan to see someone and do a piece of work and baby will be asleep or unsettled, and so that can be quite difficult. And one of the things was that perinatal mental illness is so treatable, and that we get to see people really, really unwell, and we get to see the progress that they make, see them get well and go home, see them happy and smiling and returning to their families. And that's, yeah, that came up more than once. So I just did a little bit about postpartum psychosis. I think it's something that can affect anybody, and I think that's one of the most difficult things around postpartum psychosis, that someone might not ever had any difficulties with their mental health before and then find themselves with postpartum psychosis, which can be scary for them and also family and friends around them. It is a serious mental health illness. It can affect someone soon after having a baby, and it can affect about 1 in 1,000 mothers after giving birth. It should be treated as a medical emergency. So if at any point in your careers you see a new mum acting strangely, acting kind of out of character, it's really important that they get help as soon as possible. And I think sometimes it can be lost that it is a medical emergency. It can get worse rapidly, and the illness can risk the safety of mum and baby. The ways to get help is to see the GP. You can call 111 option 2 if you have any concerns. If you're already under services, you can call the crisis team, or we've had patients go straight to A&E if they've felt really that their partners are really unsafe and they can't keep them safe at home, and they'll be seen by the mental health liaison service there. So there is ways to get help. If we can go to the next slide. So some of the symptoms, just to be aware of, they usually start suddenly within the first 2 weeks after giving birth, often within hours or days. More rarely, they can develop several weeks after baby's born. Symptoms can be hallucinations, such as hearing, seeing, smelling, or feeling things that are not there, delusions and suspicions and fears, thoughts or beliefs that are unlikely to be true, episodes of mania, so feeling really high or overreactive, talking and thinking too much or too quickly, lots of restlessness, or losing normal inhibitions. Also low mood, so signs of depression, being withdrawn or tearful, lacking energy, loss of appetite, anxiety, agitation, trouble sleeping. And sometimes you get a real mixture of the two, so a really manic mood with a really low mood, and they can rapidly change. And often we see mums with postpartum psychosis who are just really, really confused. So sometimes, so I suppose some of the causes are, it's not clear what causes postpartum psychosis, but we know that you're more at risk if you have a diagnosis of bipolar or schizophrenia. If you have family history of mental illness, particularly if you've got someone in your family who had postpartum psychosis. If you have had postpartum psychosis after a previous pregnancy, so you've had it before, and we think that hormone levels and disturbed sleep patterns may also be involved. It's really important to recognise as well that it can sometimes be followed by a period of depression, so you can get somebody treated on an antipsychotic, and then what we see sometimes is somebody go really low and have that low period of depression and anxiety and poor confidence. Mums might find it difficult to bond with baby after an episode of postpartum psychosis, or feel some sadness about missing out on time with baby, or trying to process or understand kind of what has gone on, why they are in hospital. It's kind of never on the plan really that that's going to be part of your birth journey and your parenthood journey, so that can be really difficult for people to process and work through. If people go on to have more children, there is about a 1 in 2 chance that they will have another episode after a future pregnancy. So it's really important that when you're thinking about having children again, that you kind of talk to your GP or talk to mental health services to make sure that there's a plan in place. Yeah.
Thank you, Stacey.
No worries.
That's really helpful. I will pass the session on to Poppy, if we've still got Poppy about.
Hi.
Fabulous, there she is. Thank you, Poppy.
Right. So I'm Poppy. So it says right there, I'm a community nurse. So I'm a trained RMN, but I work as a learning disability nurse. And that's one of the great things about nursing. You can kind of swap about and change routes, which is what I did. And yeah, I work in a community learning disability and autism team in Suffolk. If you can go on to the next slide, please. So my career journey, I actually was a landlord of a pub for years and years. I thought pubs and Carlsberg beer was my calling. During my pub era, as I call it, I did lots of training and advocating for mental health of staff, particularly looking at drug substance misuse and stuff like that, because there's quite a high prevalence of that, particularly on like chefs and stuff. So there's lots of different support out there, and I was trying to advocate for better support for staff. And then when 2020 came about, was meant to be the year of the Euros, I did some extra domestic abuse training, because when football and big sort of football tournaments come about, we know domestic abuse rises, and so I did extra training on that. And then I did some volunteering in a nursing home. I loved it. I spoke to different nurses and thought, maybe this is for me. I just took a bit of a gamble and applied to do it through clearing. I had, apart from the nursing home volunteering, I had absolutely no experience in healthcare whatsoever. And yeah, clearly the NHS might have been desperate because they let me do the course. Then I did my 3-year RMN training, And one of the placements I did was on a learning disability assessment and treatment inpatient area, and I completely fell in love with the world of learning disability nursing, because it's less of a focus on recovery and like clinical recovery. It's much more of a focus on quality of life, and like a personal recovery. I personally found that it's a much more person-centered approach, but when that's also now weaving into mental health care as well. I then applied for a community post, just because I don't want to work weekends working in a pub. I did loads of that, and ward work wasn't for me. And I've been working in my post for about 10 months now, but I did my final management placement there as well. So similar to Stacey's, when you do the sort of BSc route at university, it's also big blocks of placement. So you have to do 2,400 or 2,300 hours worth of placements. Can I go to the next slide, please? So a day in the life, it was really hard to try summarize a day in the life of me, because it generally changes every single day. So I tend to be probably a little bit naughty. I'm a bit not boundaried, and I really should probably stop reading my emails at home before going into work. But I have a quick read, and then I drive into work for 8:30. I like to have a coffee and a catch up with my colleagues, because I technically start at 9 o'clock. I do a few visits a day. My big love of the job is having students with me. I love being able to share knowledge. I think knowledge is a wonderful power and gift that we've all got, and it's there to be shared. And each visit is entirely different. Each patient has very different things going on. We might, be looking at side effects of medication, looking at behavioural analysis, working with carer support, doing physical health interventions, doing blood test desensitization, using like phlebotomy skills as well, because with quite a few people in my team, including myself, have done phlebotomy training. So we do the desensitization to get someone used to having their bloods taken, and then take their bloods and do that side of it. And we do a lot of work training up care providers as well, challenging a lot of stereotypes of people with a learning disability, to sort of, some people think someone with a learning disability should just be happy chappy all the time. That's not life. Everyone has ups and downs, including people with a learning disability. So we spend quite a lot of time doing reflective practice as well, within the team, because we're reflective practitioners, but also with care staff as well, to get them to think, actually, do we have unreal expectations of what we want? This person is a human with a learning disability or not. We all have good days and bad days. I then tend to go home, write up my visits, and the notes we write are obviously incredibly detailed. We tend to do like mental state examinations for each visit we do, because we're looking at how the learning disability, how they are, but also looking at the mental health within the learning disability. So say if someone's maybe they're non-verbal and they've got potentially a severe or profound LD, you're looking at how their presentation and those behaviours can showcase things such as depression or psychosis. So sort of looking at things like that as well, and then updating all the care plans, updating assessments, emailing social workers. So we work with social workers, continuing healthcare as well as the family of the patient, the care providers of the patient. We work with our liaison teams to improve physical health as well. So there's a lot of people. Next slide, please. Some of this is missing. So the rewards, obviously, I did this more of just a nurse role, than linking it directly to my role. So obviously in nursing, it's a lifelong journey of learning and gaining knowledge. you get to watch people recover and have a really good quality of life again. You're making a positive impact. There is job security in nursing as well. There's a lot of diverse career opportunities, and you're not limited to your initial training. It's really, you work with really genuine and caring people as well. It's lovely team working. You do also get paid, particularly in nursing. They're quite big on developing you. So you've got lots of training opportunities, which also mean you can go up banding increments. So in some jobs, you might be stuck at one sort of pay grade. I know it's not all about the pay, but we all work to pay our bills at the end of the day. So it is also looking at ways you can progress on that side. Challenges, it can be really, really stressful. I'm not going to sugarcoat it. There's time constraints, and you have to learn to prioritize. You might have, visits during a day, and then suddenly you've got to do an urgent MDT, a multidisciplinary team review or something, and you've got to swap your day around and go to where you're needed, basically, which can be quite stressful to try work out. There's quite an emotional toll on yourself. So it's really important to look after yourself and have some personal resilience as well. Obviously, recovery and personal recovery in particular looks very different for everyone. And it's all about working in a person-centered approach. So sometimes a professional's recovery and a patient's recovery are two very different things. And that can sometimes be quite difficult to get used to. For someone, we might say, oh, well, personal recovery is going outside, doing this and, eating 5 bits of fruit and veg a day or whatnot. But to them, it's just making a cup of tea in the morning. And it can be quite a bit of a shift to really embed that into practice. Some of the patients I work with can be quite difficult. So I hate saying this, like challenging behaviour. So sometimes when people might not know or struggle with communication, they do sort of behaviours and stuff. So it's really important to have, so we have PMA training and personal safety training, and that's really important to be kept up to date with. So but it is a really good job. Next slide, please. If I was to give advice to my younger self, my colleague actually said the first one, which was there will be blips along the way, but they'll provide you with strength to move forward. And if I could personally, it would be don't wait for a pandemic to change career. And if you feel like you want to do something, because I think I always felt it, and I always sort of wanted to do it, but I was just waiting because of like financial reasons, hence why I put everything on hold. And I really didn't need to. There's so much support out there, like financially, and emotionally support, particularly when you're doing the degree. You don't need to feel like you have to put things on hold to do it. No. Next slide. So I thought I'd sort of pick your brains a bit. So this is someone who I work with, obviously changed their name. So they're 36. They've got a moderate learning disability, ASD, which stands for autism spectrum disorder, traits of VUPD, which is emotionally unstable personality disorder, an underactive thyroid, hemiplegia cerebral palsy, so it affects 2 limbs, a history of psychotic depression, 2 past admissions, and there's history of trauma and childhood sexual abuse resulting to her being a looked after child. So the situation is Jane is currently presenting with behaviours that challenge, which include shouting, screaming, extreme fluctuation emotions, with a liability and volatile nature to her mood and presentation. She's had an increase in urinary incontinence, and fecal smearing is currently within her presentation as well. Jane lives within a shared group home where she's putting other vulnerable adults at risk with her presentation and is limiting what activities is happening. So social work is aware and is currently trying to go to panel to get more one-to-one hours for Jane. Her medication's there, so levothyroxine is for her thyroid, risperidone is an antipsychotic, but in small doses it can also be used to help with the management of those challenging behaviours. Sertraline is an SSRI and an antidepressant. Aripiprazole is an antipsychotic, PRN promethazine, and PRN lorazepam. So promethazine is it's a PRN, it's like a sedative nature, but it's mainly made up from antihistamines, and PRN lorazepam is a benzo, and obviously PRN diazepam as well. So it's the next day, and someone rings up our duty line and they say, Jane's behaviour has increased and she is now hitting other residents and smearing in the bathroom, which is now affecting other residents using the bathroom. She's becoming more and more confused, and the care team are now making decisions to keep her at home as they have too much anxiety to take her out with fear of these incidents and her recent increase in sexually disinhibited behaviours. They want to reduce these incidents. They want to reduce these behaviours, and know she was on PRN diazepam in the past, so we're looking to have an urgent medication review for this to be prescribed. They can't cope even with the additional one-to-one in place at the moment, and fears run high that this is leading to a placement breakdown and or a route to admission. So if someone rings up, have you got any ideas sort of what your actions would be at all with lovely Jane Doe? So this is what one runs through all of my mind. So we'd look at doing physical health checks. When was the last annual health check? Yeah, I'd check for a urine infection. Yeah, definitely, 110%. I'd check when their last dentist appointment was. I'm sure we all know the pain of toothache, and it is hideous. Are they in pain anywhere? Is there any side effects to any medications? Some medication side effects can lead to your tonsil, lead to you having tonsil stones, and like your salivary glands can become like infected and they can be extremely painful. If we're doing blood tests, do we need to do gradual exposure to blood tests, which is that desensitization work? Harmful working cultures, poor management and leadership cultures impacting on patient care, which links to that they straight away wanted to have more PRN instead of looking at was there anything going on in the environment around them. We need to look at least restrictive practice, and actually are they putting restrictive practice in place? Have they got a DOLS in place? Because if she hasn't got a DOLS in place, they can't really legally stop her going out. A mental capacity assessment, looking at best interest decisions, UTI effects, and constipation. Sometimes when people have constipation, they do a lot of smearing behaviours. And we know constipation is a huge cause of concern from our leader reports, which explores the learning from the deaths of people with learning disabilities, because someone with a learning disability, only 1 in 4 people with a learning disability will live over the age of 64. The other people will sadly pass away. We need to think of person-centered planning. Is an MDT working effectively? Is there any sensory elements to it? Some people fecal smear because they like the sensory element of it. Diagnostic overshadowing, are they focusing too much on those sort of challenging behaviours and not looking at if there is a very real physical health element of it? Half-life of medication. With the cerebral palsy, she's quite at risk of falls, and diazepam has quite a long half-life, so that's something we probably wouldn't want to do. Menstrual cycle, you have no idea how much a menstrual cycle will affect someone, and it's such basic knowledge that people seem to completely forget that someone with a learning disability, funnily enough, has periods too if they have a womb. When was the last annual health check? So in mental health, you've got the serious mental illness check, which is the SMI annual check. And in learning disability and or autism services, you've got the annual health check. Behavioural analysis work, we want to work out if there's a pattern to it. What are the triggers in the environment? Is there something we can do? Again, is it sensory elements? Do we need to dim the lights a bit and make it a calmer environment for them and look at putting in reasonable adjustments. Lessons, we're looking at lessons learned from our past experiences. I don't know if anyone's ever done the Oliver McGowan training, heard of Winterbourne and read the leader reports. We're also going to be looking at trauma and working in a trauma-informed approach. She's a vulnerable adult at the end of the day, and we know there's been a past history of sexual assault, and people with an LD are unfortunately much more likely to be sexually assaulted and assaulted because of the vulnerabilities. And the key legislation we're going to be looking at is the Health and Social Care Act, the Medication Act, the Mental Health Act. Say if it came to needing a point of admission, a Mental Capacity Act, the NMC Code, the Equality Act, then you've got the Medications Regulations Act, which we'll be looking at as well. We look at the STOMP, which is stopping the over-medicating, I can't remember what it's for now, but it's stopping the over-medicating of people with a learning disability. And like, we don't want people to be on antipsychotics because we know they've got quite bad physical health side effects. So that's all the stuff I think of when I do an assessment, and probably much, much more that I haven't written down.
So thank you both so much, Poppy and Stacey. You've been great. Thank you so much for joining today. As I did mention briefly at the start, it would be great if you guys who have joined today, if you could just let us know how you found today's session. We're always looking at ways to improve, and we are open to suggestions. So please do scan the QR code if you're able to, and just complete the very short form that we have put together there. Thank you so much for joining. Have a wonderful evening.